Hello. Massachusetts is the home of Romney Care, which originally inspired the Affordable Care Act. What can we learn from it? Welcome to Care Talk Live in Boston, where we talk about how healthcare works or doesn't work in America and answer your health insurance and healthcare questions. I'm Laura Packard, cancer survivor and healthcare advocate, here to help you. Please text or call in your questions at 202-838-6837 and we'll answer them in future episodes. Be sure to subscribe to my channel or podcast wherever you get your podcasts to get next week's show. In today's episode, healthcare expert Alex Sheff shares what Massachusetts has learned about making healthcare more affordable and available. Welcome to Alex Sheff, Director of Policy and Government Relations at Healthcare for All Massachusetts.
Thank you. Thanks for having me.
Thanks for joining us. And so let's start with the organization you work for, Healthcare for All Massachusetts. What are you and what do you do?
Great question. So we're really a healthcare consumer advocacy organization. We've been around a long time, since 1985, actually. We were one of the first of, I think, this type of organization in the country, but now there are organizations like this in states around the country, and as well as sort of national umbrella groups doing this work, obviously federally. We really do three things, we say, and the first thing is the heart and soul of our organization is a helpline. We take more than 25,000 calls a year. We do it in 5 different languages, and we help people get enrolled in coverage, stay covered, navigate their coverage, and frankly, that's kind of the center point of what we do. It's our sort of direct work with consumers. So that's big part number one. And then the second thing that we do is we've grown more recently to do more and more outreach and engagement work. This started actually during the pandemic, where we were doing work around vaccine equity and outreach in communities. It continued through the Medicaid redetermination process that happened when the public health emergency ended and everybody had to be redetermined for Medicaid. And recently, we've also done work around the closure of some of the Steward hospitals and the crisis we had there in the state. So that's our outreach and engagement work. And then really what we do as an organization is we take both of those things and what we're hearing from community members, from helpline callers, and that feeds into our advocacy work. And that's where we are doing primarily state-based advocacy. We're working with the state legislature, with the governor's office, with our Medicaid program, which here is called Mass Health, our connector, our ACA marketplace, to really try to advocate for, healthcare coverage and access and equity in the state. So that's kind of the three different parts of what we do.
So tell us about healthcare in Massachusetts, in that Romney Care would, under then Governor Romney, sort of set the stage for the Affordable Care Act and healthcare expansion in the country. So what was it like before Romney Care was a thing?
Yeah, it's a good question. And Massachusetts actually has a rich history of health reforms, even preceding this 2006 health reform, now Romney Care that you're referring to. And so really it was kind of like multiple waves of reform in the state. But 2006 was the big reform that tackled coverage in the state. And it basically did a couple of big things. It created this sort of like subsidized market for healthcare. It also included both an individual mandate and sort of an employer contribution mandate. And so that structure is what then, became an important model for the Affordable Care Act. The other important model for later reforms were a lot of the insurance market reforms. So things like, community ratings. You can't charge people more because of their health status, or things like that. And those were actually in place before the 2006 reform, but again, part of those sort of previous waves of reform that led to it.
And so the result of all this is that Massachusetts has the lowest uninsured rate in the country. Why is that?
It's a good question. I think there are a lot of things that go into it. I will say it starts with what we like to call sort of our culture of coverage. That is to say, and this was one of the key factors that led to passage of that 2006 reform, this sense that like as a state, we just believe that everybody should have coverage, everybody should have access to care. And it's a broad ethos that sort of is held across a lot of different stakeholders, from folks in the healthcare industry, hospitals, insurers, et cetera, but also the business community. That was a really important component to the 2006 reform. So I think it starts with a culture of coverage, and everybody kind of buying into that. And then I think, then we put pen to paper, and what that meant was really building out this subsidized coverage. At the time, it was called Commonwealth Care. It's now, in its current iteration, known as Connector Care. But that really made coverage truly affordable. And actually the subsidies, in terms of what the premium levels it made possible, those kind of lower premiums and the lower out-of-pocket costs, the no deductible plans, all of those were things that made coverage kind of actually appealing, actually affordable for people. So in addition to the mandate, in addition to the employer contribution, we really made coverage worth it for people. And there's been research that's looked at and said, the every dollar you put into that subsidy, in terms of lowering the premium, increases the amount of coverage and decreases your uninsured rate. So I think that's a really important cornerstone to it. But you do have to have multiple components, and I think that initial structure, subsidized coverage to make it affordable, an employer mandate or contribution, and then an individual mandate, I think, was part of that original secret sauce that really lowered the coverage rate.
And so this was just this was just a piece. There was another piece. You mentioned that there were several stages of healthcare reform in Massachusetts. So can you talk about what happened next? What was the next piece after this?
Absolutely. So the 2006 reform is incredibly important. It's the thing that sort of sets the course for lowering the uninsured rate in the state, gets everybody covered. But pretty quickly, I think what was not addressed in that reform was cost containment. And the state starts to realize, hey, we have to do something on cost containment if this is going to be sustainable and manageable for the state. So it took a few years, but by 2012, the state passed sort of a second wave of reform that addressed cost containment. There are a couple big components to it, but one of the biggest was the creation of a healthcare cost benchmark, and Massachusetts kind of again setting the pace in the way that we did for coverage in 2006. When it comes to the benchmark, did a similar thing. So in 2012, we were the first state to create this cost benchmark that basically just says healthcare costs shouldn't be growing any faster than overall, I would say, economic growth in the state. So, that's the marker. And, we built a structure to surround that, the data that's needed to feed that, the the stakeholders to set the benchmark, monitor the benchmark. And then, of course, that we can talk about what it means to sort of have accountability or enforcement around that benchmark as well. But that was the next big step. Although there were a few things left out of that step, which we can talk about too.
Well, what happens if healthcare costs are more than the benchmark? What happens next?
It's a good question. So the short answer is there is a process. Basically, there's two different agencies involved here, but the one that kind of monitors it, the data folks, if they see that costs at a given entity, and that could be like a health system or an insurer, are growing at a faster pace than the benchmark, they can refer those entities to the Health Policy Commission for a cost review. And what's known in the state as a performance improvement process or PIP process. Importantly, the HPC doesn't have to go through with it. They can look at the circumstances for that entity and say, oh, there's a really good reason, or this, or that, or they're treating predominantly sort of like public payer patients, and there's a good reason for it. So they don't have to move forward, but they then can move forward with the performance improvement process. There was one that was done a few years ago for our largest health system in this state, Mass General Brigham. And basically it involves the sort of a mutual plan, a plan that gets proposed from the entity, that gets signed off on from the Health Policy Commission, and then gets implemented, and that gets monitored. There are some, I would say, small penalties for noncompliance, but there are some penalties for noncompliance with that process. But, it relies a lot on the idea of what has sometimes been referred to as naming and shaming, but I just like to think of as sort of like, like broad social accountability. And I would say, we can talk about the ways in which the power of the benchmark in Massachusetts has maybe waned a little bit in recent years, but at least initially it got a lot of attention. I mean, like the governor shows up, the media was paying attention. And so, it would matter if you were a stakeholder and you didn't want to be kind of, on the wrong shamed. Yeah, you didn't want to be on the wrong side of this. And so I think that was a powerful tool to just have this kind of level of transparency and everybody focused on it. Over time, I think that power has waned for a variety of reasons, partly because of what was left out of that initial structure, but also partly because it stopped being the kind of big public attention grabbing tool it once was.
So for Massachusetts, you can kind of look at it as multiple stages. The first stage was making sure everybody could get affordable health insurance. Second stage was getting a grip on how much everything in the health system costs. But there's some pieces left out of that. So can you talk about that?
Sure. Yeah. So honestly, the big piece that was fully left out of that was basically prescription drug costs. So when the Chapter 224 is the law that we're talking about in 2012, and it basically didn't include prescription drug costs in that performance improvement plan process. So, and there was limited reporting of data around prescription drug costs as well. There's some data, but there's probably not as much as we needed on price. And there was no real accountability mechanism for what to do about it. So that was really the gap in that initial law. There were some other ways that I think you could argue now with like 10 years of learnings and hindsight, we could say, well, we could make some updates here or there. We could strengthen some things, maybe enhance the penalties, maybe create more flexibility in the kind of benchmarks for referring entities. But I think, the main thing that we're focused on at the moment has been bringing prescription drug costs into the process. And I could talk a little bit about it. At the end of our last legislative session, at the very, very end, we passed some reforms to do a little bit of that, if that's helpful to go into.
Yeah. So what all has Massachusetts been working on and what's to come?
Yeah. So I would say here, what we got done in this bill at the end of the last session, which were some really important steps. The first was we brought prescription drug manufacturers and pharmacy benefit managers into the cost trends process for the first time. So they will also have to testify at the benchmark hearing like other stakeholders, hospitals, insurers in the state. So that was a really important step. The second thing is that we enabled more data reporting than we have before on prescription drug costs. So I think that we're going to have to wait and see whether that is successful in the way that it's been structured. But I think it was a really important step to get some additional data. Third thing that we did was it created a new Office of Pharmaceutical kind of research and analysis at the Health Policy Commission. So if you think of it, you've got like the information, you've got folks testifying, you've got data you need, but now you have an office to actually analyze that data, put out reports, do the research we need in order to say, to sort of focus on the challenge. And then the last thing that was done, before I get to what wasn't done, is there were some really important provisions in that bill that focused directly on providing relief to consumers who are really feeling prescription drug costs in the state.
Sure.
And so in particular, what we ended up doing was focusing on chronic conditions. And we, in particular, focused on chronic conditions that disproportionately impacted people of color and low-income folks in the state. So it ended up focusing on diabetes, asthma, and heart conditions as the three conditions. And we basically said, for all the fully insured folks in the state that are state regulated, there has to be one generic option for each of those conditions, one generic medication that has a $0 copay, totally free, and one brand name option that has a $25 copay. So, it enables, I think, like just some guarantee of some affordability for these chronic condition medications. And again, there's just really good research. Like it's intuitive, but it's worth saying out loud. Like we want people to take their long-acting asthma inhaler because they're much more likely to stay out of the emergency room. That saves costs in the long term. Same thing with insulin. But putting it together in this package, I think, was really important. And so that will go into effect in January, and we're excited about that provision. So those are all the things we did. Very exciting. What we're working on now, what the next step is for us is accountability, I would say. So, what we didn't get into there was, what happens with, we find that there are prescription drugs that have prices that frankly aren't aligned with the value of the drug. And I think that's where we've been particularly focused, right? It is high cost drugs, but it's in particular high cost drugs, or drugs where we see a lot of cost growth, where the value isn't always aligned with the, with the price. And so, I think, what do you do in that situation? And so the advocacy we're working on now is saying, okay, there needs to be a process for the HPC to do, high cost drug reviews, and to even go as far as setting upper payment limits in the state. And we've seen a couple other states kind of pursue this route for, drugs that they think where there's a misalignment there. And so there is legislation pending in the legislature, and we're continuing to advocate to see if we can get that done. Excellent.
So for the pieces, the whole country followed on, copying off of Massachusetts's work for the Affordable Care Act with getting more insurance coverage to more people. Why do you think that some states have copied your work on holding down costs, but why do you think that the federal government hasn't done anything on, or hasn't gone as far as Massachusetts on bringing down the costs of healthcare?
It's a good question. The short answer is, and it's worth saying, so I think there are maybe 8 or 9 other states now that have implemented cost benchmarks, which is great. The Affordable Care Act did include some cost containment provisions. I think one thing we haven't talked about that was in the Chapter 224 law was this real move to try to move away from fee-for-service payments and towards accountable care organizations, or risk-based payments for population health. And there was a lot of that in the Chapter 224 law, and there was a fair amount of that in the Affordable Care Act. I think there's been mixed results on it. I would say in a lot of ways you could point to improved outcomes, maybe some modest cost savings, but I don't think it's maybe achieved all of the cost savings we need. So I think, there were those areas where we have seen some more federal action. At the same time, cost containment is hard. There are a lot of industry stakeholders, involved, whether it's prescription drug manufacturers or pharmacy benefit managers or hospitals and hospital systems. You can go on, but I think it is a challenging area to do reform in. And obviously Congress can sometimes be challenged in that area on a variety of fronts. So we're glad to see states kind of taking the lead and taking action on some of this. And in some cases, the insulin cap was something that was done at the federal level for Medicare. Some negotiating of drug prices in Medicare, also an important step. So there is some iterating going on. Those changes were not able to be implemented in the commercial market as part of the reforms under the previous administration. But, I think that's sort of the next step to take. And so there's some iterating here, I think, between states and the federal government. And so we hope, we keep doing that. They keep learning from states, and states keep learning from what the federal government can do. And we kind of move forward as best we can together.
And it's really tragic that this big bill just passed Congress and it just cuts rather than trying to control the problem, which is that healthcare costs too much. So, this bill's version is, well, we're just not going to pay, but that means that millions of Americans will lose their healthcare. So there just isn't or wasn't the will to face all of these powerful interests that spend a lot of money on lobbying. The system doesn't work for so many of us, but it is making some industries and people very wealthy as it stands. Why does America have more expensive healthcare than everywhere else in the world? Pick a country and you see they pay dramatically less and often get better results.
So when I went to grad school, one of my professors was a guy named Uwe Reinhardt. He was this great health economist, and he wrote a book called "It's the Price is Stupid." So I always like to go back to that. I think it is a complicated challenge to solve, but in the end, the answer is, to some degree, we're not willing to, I think, confront the pricing challenges we face, in particular when it comes to prescription drug costs. I mentioned that in part because we've just seen in the state data, it's not the only problem, but it was the largest portion of cost growth in the state. It was growing at more than 10% in the last years that we have data for, even after accounting for rebates. So it's really, really driving costs, and it's not just utilization, it is prices. So I think there's just no way, I think, to address the challenge without looking at prices. And a lot of other countries, it's, have just been willing to address prices in a way that we haven't, and through different structures. And that doesn't have to be single payer. It can just be, there are lots of different structures for figuring out how to sort of leverage either, the state or the federal government's capacity for negotiating prices in a way that makes sense. And again, that doesn't mean we don't, there should be innovation. We are a consumer advocacy organization. We want consumers to have access to innovative medications, but there's a limit to that. If it's so expensive that it starts to put that care out of reach for people, then it, you start to limit the usefulness of that. And so, there should be reward for innovative work, but it's important that prices and value be aligned, and it's important that consumers be able to afford that. And yeah, that's I think a huge, a huge challenge, and we're trying to figure it out like everybody else.
Yeah, because what good are medications if people can't afford to use them?
Exactly. And I will say, our approach is often to try to address both things at the same time. System level cost reform, these things like negotiating prices, or setting up our payment limits, having cost reviews, all of that gets at the system level cost. But then these kind of more direct consumer facing reforms around capping copays for chronic condition medications, those kinds of things, and putting those together. Because I think it's important for folks to sort of experience, there have to be system level reforms. You can't solve the problem if you're not getting at those underlying cost drivers. But it's also, if people don't feel that, then they have less, faith in the system to actually be helping them. And so I think you have to do both at the same time.
Right, because I think in many places, maybe in most places, a lot of people have lost faith in, when they see sky high deductibles, sky high copays, such that the insurance they have is not something that they can really use. That people give up on the whole idea of healthcare. And we start seeing more wellness marketed as healthcare and supplements and stuff that's not actually based on science, but is making the people pushing it very wealthy. And it's so frustrating to me to see this current administration marketing victories like cooking fries in beef tallow as a health victory, while while enabling legislation that will take away health insurance from millions of Americans. That's not a good trade.
No, it's not a good trade. And it, I think it's worth just thinking through what happens when to your point about this reconciliation law that got passed, what it means when you cut health insurance for that many people. And it's ripping away coverage from people. And in a way that it doesn't stop them ultimately from showing up at the hospital at the very last moment when they're really sick. So we will pay for this eventually. People who pay insurance premiums will have to pay for it. States will have to figure out how to cover the cost, but in the least effective, least efficient way possible, as opposed to helping people get and stay covered and get, basic care, access to primary care, be able to take their prescription medications. Those are all the things that people just stop doing when they're not covered. And so I think that's the consequence, and that's the challenge here.
Right. And we know with people that can't afford insulin, we know what happens is that people get sicker, people lose limbs, people ration insulin and die. And so again, people could show up in the emergency room and die. And just we wind up paying for healthcare in the most expensive and least healthful way. There's so much human suffering, and and the numbers are bad too.
Yes. Yeah.
So it's on top of that.
And not to get too wonky on you, but I mean, there's some of these changes also, like there's changes to Medicaid that, we'll lose lots of coverage from Medicaid, but there's also changes to the Affordable Care Act marketplace coverage. We think it essentially amounts to an attempt at a backdoor repeal of the Affordable Care Act marketplace coverage. And one of the impacts there, it's not only that people will lose subsidized coverage and then lose coverage, their costs will go up, all of those things. It will also impact the risk pool for the market. So essentially, not only is it going up, the costs are going up directly for people, but then the sort of underlying premiums are also likely to go up on top of that. And it really risks a potential. I mean, we used to, in the pre-ACAs, talk about insurance death spirals. And so I think you do have a risk that, premiums continue to go up and up if kind of younger, healthier people who are now no longer eligible for subsidized coverage lose that coverage, and now you sort of have this problem in the market. So there's a lot of ways in which the impact will be, tough on people. And at the end of the day, it means people who lose coverage, have their coverage ripped away. People, their costs go up, their premiums they're paying go up. We haven't talked about the impact on medical debt, but obviously this has a huge impact on medical debt that people end up carrying and the consequences of that. So yeah, lots of both bad health outcomes and bad financial outcomes for people.
And this hits personal for me because my insurance is through the Affordable Care Act. So I am dreading getting my letter in the next couple of months and seeing how much they're going to charge me next year, because I have to pay it. As a cancer survivor, whatever amount they charge me, I can't go without insurance. But again, talking about death spiral, when only the people who really, really, really need health insurance pay for it, then the costs increase, as the people who can choose not to get health insurance leave the marketplace.
Sure.
So, I mean, this is a problem that could still be somewhat solved in that Congress has chosen not to extend the subsidies. When they come back in September, they could choose to do something. It's my understanding it's going to be a mess regardless because insurance companies have already posted their rates and so on, sometimes posting, different sets of rates for if so this is a big mess. It is a self-inflicted mess because Congress just did their thing over the past few months. And instead of doing something that would help people, they chose to give tax breaks to rich people and hurt everybody else on the way. So what can the rest of the country learn from Massachusetts, good and bad, with everything? Like, Massachusetts has been on the forefront in so many different parts of healthcare and making sure people get covered. What should the rest of the country be paying attention to?
Yeah, I think a couple of things. So the first is I go back to this kind of like culture of coverage and culture of care, and this idea that you really, I mean, every state is going to be facing really difficult choices. And thinking about like, what are your values as a state, as a community? Like, how do you want that to be reflected in your state laws? That's what Massachusetts did to bring about health reform in 2006. It's what we, hope to do moving forward. So getting really clear on that is one of those things. Getting stakeholders to the table, making sure people understand the consequences. I think a lot of people look at something like this and they go, oh, well, I'm not on Medicaid or whatever it is. And like, our system is interconnected. If you're not on Medicaid, but the maternity ward at the hospital that you deliver at is like has a lot of Medicaid patients, and suddenly those people are uninsured and they're not getting paid, and that hospital closes down the maternity ward, it's going to impact you, even though you don't have Medicaid. So I think helping people understand even if you're not getting care at that kind of hospital, that it will impact your premiums when there's this amount of new uncompensated care in the system. So I think helping people understand the consequences across the system is really important. And like the lesson for Massachusetts was, we investing in these programs is what made them successful. So I think, as states, tackle their budgets, sort of keeping that in mind, even as they face these really difficult challenges.
Well, I think there's a lot that people can learn from Massachusetts. And thanks, everybody, for joining us. Thank you, Alex, for joining us.
Absolutely. Glad to be here. Thank you.
Yes. And thank you, everybody, for learning today what's happening on healthcare in Massachusetts and how the rest of the country can learn from this. Please text or call on your health insurance and healthcare questions at 202-838-6837, and we'll answer them in future episodes. Join us next week for more on healthcare in America. Be sure to subscribe to my channel or podcast wherever you get your podcasts. My name is Laura Packard, and this is Care Talk.